My name is Andy Jones. I'm the CEO of Ramsey here in the UK. Ramsey Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsey Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsey hospitals to refer their patients for high quality healthcare. So Ramsey has got a long-standing set of values called the Ramsey Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsey Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsey, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening, ladies and gentlemen. Welcome to tonight's BOFAS Lecture of Distinction on Posterior Malleolus and beyond. My name is Yasser Ghani and I'll be your moderator tonight. Tonight's speakers are Mr. Molloy and Professor Mason from Liverpool University Hospitals. Thank you to Ramsey Healthcare for sponsoring tonight's lecture. Just a couple of notes. Please submit your questions using the Q&A icon at the bottom of the Zoom screen. Attendance certificates for CPD will be issued following your submission for feedback. And as usual, you should receive an automated feedback email after logging out of tonight's broadcast. If you don't receive the automated email in the next 24 hours, please use any of the previous links and then use the new code in the Zoom chat. Tonight's speakers need no introduction. They are internationally renowned for their foot and ankle work. The distinguished speakers are Mr. Andy Molloy, Senior Foot and Ankle Consultant and Honorary Senior Clinical Lecturer at University of Liverpool, and Professor Lyndon Mason, who was awarded the Hunterian Professorship in 2019 for his work on ankle fractures. So without further ado, over to Mr. Mason and Mr. Molloy.
Thanks, Yasser, and thanks to BOFAS for putting this on. It's a delight for the two of us to talk again. We obviously gave a talk on posterior malleolar fractures last year, which is obviously available on the BOFAS website. So for any of the background to it, that's there. So what we're going to do today is really as a fireside chat to talk through cases, a little as you would do in a trauma meeting or in a foot and ankle MDT meeting, so we can get to some of the slightly, I suppose, esoteric points, but also how these cases can be slightly different each time and what our decision-making process is. So I'll ask Lyndon about the first case, really. So Lyndon, this is a posterior malleolar fracture, which is immediately stable on this weight-bearing radiograph. How would you further investigate this?
Yeah, so it would be quite regular to come into clinic with a weight-bearing radiograph, and this is obviously a weight-bearing radiograph with a posterior malleolar fracture. Now, we do have an increasing number of posterior malleolar fractures. We have treated conservatively that were undisplaced, but to know it's undisplaced, we would need to get a CT scan. So my initial investigation after this would be a CT scan. But you can see on this one already that on the lateral, the talus is already slightly subluxed posteriorly, and we have displacement of this posterior malleolar fracture.
So, I mean, how big do you think the posterior malleolar fracture is?
No idea. That's the truth. And I've, like yourself, Andy, I've looked at thousands of these, and I still don't have a clue on these X-rays of how big the posterior malleolar fracture. A percentage is a unknown entity on these radiographs. We just to label that point, obviously, there's 9 papers in the literature showing that the posterior malleolar fractures can't be really viewed on your X-rays. So some papers saying 22%. So only 1/5 you'll know how big the fracture is. And obviously we've done our own paper on this, be it it's not published yet. It's been presented, and it's been presented in BOA this year, showing that if you are actually going to look at the morphology due to our classification system, you can get down to only 24%, 17%, especially the rotational pilons are the worst ones with this, that you just don't know what type of fracture is. So you can think the type 1s, for example, are type 3. So even the very small fractures can look like a big fracture, or the very big fractures can look like a small fracture. So we just don't know. So yeah, so this is the CT scan for this one.
Yeah, so I mean, I think, as you said, it's 2A and 2B, which you can mix up with the other types. There's just no way of telling. So what difference does that really make for subluxation and things?
So there's a biomechanical paper that came out last year showing that the rotational pilons are rotationally unstable. So we didn't know this. Obviously, when we started this work 5 years ago, the Haraguchi classification thought these were all avulsion fractures. But you can see with this one, it's a rotational pilon, but you can see that be subluxed. And this paper came out last year showing that you can actually quantify the subluxation on these CTs also.
We've published about our treatment algorithm before. So, I mean, how would you approach this one?
So this is, I guess, the Blue Peter, this is how I did it earlier, I guess, situation. But you can see that the fibula plate has been put on posteriorly, and I've also fixed the posterior malleolar fracture through the same incision. This is our algorithm. And for this one, a 2A, we typically would do a posterolateral approach. So this one has been done as per algorithm, I guess. Obviously, this is based on our paper, came out in Foot last year. Do you want to talk about this paper, yeah, Andy?
So I think, I mean, we've had this published, but I actually think it's almost the best bit of work after the classification system, because it really leads you to what approach should be used, and it really is just what can be visualized. It's not that we have a preference for doing one over the other, but if you look at this clock face, essentially this was done on cadaveric specimens from making each approach, putting K-wires in to take the soft tissues as far apart as they could do, and how much can you see. So you will see a lot of papers out there saying that they just use one approach for it, but from what we showed is that you just can't get to all parts of different fractures from one approach, and this is right. They obviously didn't like what I was saying, but it is, yeah. So it's absolutely critical if you're going to address each part of the fracture to follow the algorithm based on what we showed. So, I mean, the other thing with that is that how do you position these patients? Would you position them the same way?
So I So I don't know what you felt. So so this is based on that paper. You can see the different bits through each bit, and you can see the posterolateral approach. You can see the fragments of your 2A here, but your type 2B, for example, you can't see that through the posterolateral, which is why you need other incisions. But I started them all with this prone position, which was, so this is 2 sheets, one on top of the other. In between them, we have a Montreal mattress, and then we've dropped the leg out of the way, the other leg, and this is obviously the injured leg. And then we put a sandbag underneath this to tilt the pelvis back, but otherwise you'll tilt towards the dropped leg side. So this was my go-to way, but when I had a anaesthetist that was the same anaesthetist all the time, this was very easy to do. But I must say I've migrated much more now to this recovery position prone, where the top half is lateral, because the anaesthetist, number one, preferred it, especially if anaesthetists are not that happy with the prone position. And also in the bigger patients, or the patients they're worried about going prone, it's much easier to do. But to do this, you have to do a bad side down lateral to start with. So you turn the patient laterally, and then you take the leg and keep on moving the leg till it's in this equinus position, but the top half with some lateral supports remain in this recovery position.
So it doesn't quite show up on this, but the important thing with this is that the torso isn't quite fully lateral, but is in a sort of sloppy lateral position, sort of partially facing down. And I think, as Lyndon said, the key that this is made is that just going standard prone, if you're doing a posterolateral approach, is absolutely great. But if you need to do anything to the anterior part of the medial malleolus, trying to get to it via the prone position or bending the leg up into the air and having to do things upside down and the wrong way round is really difficult. And this makes everything a lot easier. So as you'll all know, is that the key to any of these procedures is fixing a fracture is fixing a fracture. It's just putting a plate and some screws on it. It's actually getting the approach right and the position right, so you can see what you want and you can decrease your stress levels as well as the anaesthetist's.
Maybe just moving on to case 2. Andy, I'll grill you on this one if that's okay. I think it's one of your cases. So this is obviously a very displaced fracture where the talus has gone posterolateral, very convoluted fibula. So I'm assuming you want further investigations?
Yeah, so when you look at this, obviously it's a very low fibula fracture. There's gross displacement, and you can't, it's posteriorly subluxed, but we can't see the posterior malleolus at all. So there must be some injury at the back. But I'd also point you on the AP that just in line with the lateral cortex of the fibula, there is like a double white shadow there. Now, one of the things that we found is this always means that there's a significant Wagstaff fracture present. So yeah, obviously we get a CT scan on this. And thankfully being a little better reduced by this point. So you can see there that it's a 2A posterior malleolar fracture. But when we go through to the next views, as you can see how large that Wagstaff fracture is off the top. Now, with this is the 3D CT, so you can see that's a significant fragment off the front. Now, one of the other bits of work that we did when we first did it was about the amount of what was unstable in the syndesmosis. So by fixing the 2A back on is that you'll fix the PITFL back on. But what we found is for different types of fractures is that there were differing levels of either just posterior instability or full syndesmotic instability. So that really was just the PITFL injured, or was the AITFL and the syndesmotic membrane injured as well. And you can see that on the type 1s, full syndesmotic injury was really the most prevalent thing. And this decreased as we went through it. But for these type 2s, such as that one that we've just shown, is that almost a third of those had full syndesmotic instability. So you'll need to check carefully for that. And if you see on the anatomical specimen here is the 3 parts that you can injure, and that we need to make sure that it's not just the back that's gone off, that we haven't taken off AITFL either with or without a big bony fragment, and the syndesmosis membrane as well.
And when we done this paper on the posteromedial aspect as well, Andy, one thing that amazed me was the larger the fragments, the less chance that you had instability of the syndesmosis. It was either bone or ligament. So if the ligament went, it was less bony injury, and if the bone went, it was less ligament injury.
Yeah, I mean, my feeling, and there's no way we've got of really proving this, but in my simple mind, it just sort of felt that the larger the bony fragment was, that means that the force has been transmitted through there as opposed to the rest of the syndesmosis, which I don't know whether that makes sense or not, but it did seem to correlate in our study. Now, do you want to talk about the size of the Wagstaff fragments?
Yeah, so because that correlated with this as well, is that the larger fragments didn't necessarily correlate with the syndesmotic injury either with the Wagstaff. So the smaller fragments could still have a syndesmotic injury, and the larger fragments sometimes didn't.
The thing to take home from this is that, like, you want to go and fix your posterior malleolar fracture back on, but you must keep on assessing the rest of the syndesmosis. So with this one, we initially fixed the back to start off with. So if you put your lateral plate on first of all, you won't see the posterior malleolus fracture. So you need to get this, and once you've got that in the correct position, is almost always your fibula is going to be out to length. So fix that with one screw at this time, although we've changed with some of the plates now, and then fix the fibula. And then if you look from this sort of AP view, once we've fixed it, is that we still have that large Wagstaff fragment. Now, if it's a smaller one and your plate will allow it, is that you can suture it back down or use intraosseous sutures, but this one was big enough to allow for a 2.7 screw. But even after fixing the Wagstaff down, as the syndesmosis membrane wasn't quite intact, as it just felt like it was giving slightly, so we put a syndesmosis screw through there as well. And then we've got we always tend to follow up our complex ankle fractures for 6 months. So this is a 6-month x-ray, which quite pleasingly doesn't show any increase in arthritis radiographically.
Great. So case 3.
So what type of fracture would you say this would be? See if you can guess on this one, whether you can remember or not.
So
go through.
Obviously, we've got this double shadow medially, which usually means that it's a 2B fracture. So obviously, we can only see one fragment on the lateral. But on the AP, if you've got this double shadow, you're thinking that you've got a splitting out of that 2B fracture.
So that's just trying to get Lyndon to show that he's clever. But the thing that's important with that is that obviously most of us, or pretty much all of us, only have fluoroscopy when we're fixing it. But when you get an AP view, if you can still see a double shadow, this hasn't been reduced properly. And we'll come on to that a little bit later. So what type of fracture is this? And what approach?
So this is a lot more complex than, especially outside of our algorithm. And the reason for that is that not only got the 2B fracture, but you've got this comminuted anterior collicular fracture making a Y-shaped medial malleolus. But also you have this high fibula fracture, which is really difficult to treat a high fibula fracture with a posterolateral approach. But in my hands, I find it is. So it means that, like, so our algorithm, it has to change a little bit for this one, because of the high fibula and also this comminuted medial malleolus. So this is the posterior aspect.
So if you just go through to the next slides for us, that obviously shows that the syndesmosis doesn't look too happy. But are there any problems that you can foresee in fixing this 2B fracture? And how would you approach it? Which bit do you do first?
So with this one, due to what we found with this, as I said, compression of the posterolateral aspect causes a medial translation of the medial side. Is that if we do the lateral side first, unfortunately, we're going to have a malreduction. Well, we found that with some of our early cases, you're more likely to malreduce your medial side. The medial side is usually the easiest one to approach first to get that large chunk back. And that was what we did. Also, bringing your medial posteromedial approach more anteriorly towards the front allows you to get to the anterior clavicular fracture.
And so I think the key point you say there is that it's an extensile approach, so you can keep on going up and keep on going down. I'm sure we'll talk about that later of it. So do you want to show your final handiwork?
So as you can see here, we have a plate on the posteromedial side, keying in that the apex of that medial fracture. We have that small screw, the headless screw here in that very small anterior clavicular fracture. The fibula has gone on laterally because that's much easier to fix your high fibula. And that means that you can actually put your finger across and get in to reduce and fix this percutaneously, this posterolateral small fragment, which has meant that this one has been done percutaneously.
And as you said, I mean, this was a case that we did together, wasn't it? But it was that fibula was an absolute pig to get reduced. Yeah. So don't think you've got everything solved when you've just done the back. Is actually the most challenging part of this is that high fibula with the big butterflies. They're difficult to get out to length. So I think that's the thing that's just crucial that we ensure that we get.
Yeah. So case 4. Yasser, do you have any questions?
Yeah, so I'll just chip in. Please, the audience, if you have any questions, just channel them through and I'll keep asking them after a few cases. So that's brilliant 3 cases. Now, there is one question which I think probably is, you described in case 1 a posterior malleolar fracture, but what about the shortened and rotated distal fibula, which wasn't commented on? Presumably you fixed this too, and I think you have probably answered this anyway, that you will go on and fix this.
We only fixed the posterior malleolar fracture first, just because otherwise you can't see your reduction on when you fix the fibula. So as soon as you fix the fibula, the plate's in the way. But sometimes, especially if the fracture is 2-3 weeks old, it's actually quite useful to get a reduction on the fibula first with a clamp. Because it's much easier to bring the posteral malleus down with bringing the fibula down with a reduction, and then putting fixation on the posteral malleus before then putting the plate on the fibula. And sometimes it's much easier to do both together than to take down. Otherwise, you can convolute the posterolateral fragment by trying to bring that down by itself.
Excellent. And then that follows on. So the other thing will be then, do you have any tips or tricks when you actually have to do the fibula fixation first? How do you visualize your appropriate reduction of the posterior malleus then?
So it depends what type of posterior malleus it is. So for example, if it's a type 3, you can visualize your reduction through a medial posteromedial approach, because that's where the corner of the fracture is, for example.
Yeah.
If you have to do the fibula first, I would generally put some clamps and wires to provisionally fix it without putting the plate on, and then fix so you can visualize, and then actually put the plate on.
Yeah, so I must admit, I feel the same, is that if it's an older fracture, which unfortunately seems to be happening more commonly just because we're slightly inundated, is that if there's some early callus and fibrous tissue, you just trying to get the posterior malleolar fracture, which will be slightly osteopenic at this stage, is really difficult. So just take the fibula down as you would do. And if you want to try and aid it, as Lyndon said, I find a 1.6 or 2 millimeter wires just going across the incisura or even into the talus is just really helpful to get them down, and it doesn't get in the way of you visualizing that you got the posterior malleolar fracture down. So you can you can see it directly, obviously, but it's always more difficult if there's been some comminution that's partially resorbed, is you need to be able to get a true lateral x-ray. So it's one thing to always check at the start, is that with the radiographer that you can get a decent view.
Excellent. All right. I think we should move on to the other cases then.
So this is a ankle injury which has widening the medial clear space, widening the syndesmosis, and this tiny little fragment, be it that the CT has shown this to be a tiny fragment as well. So and when they've had a weight bearing view, it's actually shortened, so it's axially unstable, so i.e. a major nerve fracture, which is axially unstable.
So, I mean, I think one of the important things with this is that you've got a weight-bearing X-ray on the right of the ankle, but obviously with the back slab on, it's not a weight-bearing X-ray of the knee, and so you won't always see the shortening that is apparent there. But if the fibula looks short, is that we do tend to use a lot of tightrope, and they work really excellently, but they don't provide any axial or very little axial stability. And that's been commented on in all the biggest series and the biomechanical papers that they've done. So if you think it's a fibula that is at risk of shortening, is that you need something that's going to be robust and resisting axial movement. So for these, as well as if you are going to use screws as well, and I'm not aware of any study that's been done with a tightrope, is that some friends of mine from fellowship, Kadakir and Espinosa, did a study where they showed that the strongest construct is to use a 2 or 3 hole plate, put your syndesmosis fixation through. So this is what we went and did on this case, where just one screw is necessary, and we can, if we have time at the end, we can have a debate about whether you should take syndesmosis screws out or not. But if you are going to take them out, I'd leave them in for at least 4 months. But if you do take this syndesmosis screw out, you've still got a tightrope in, you're not as worried about leg failure, and the axial problem will have gone by then, because it will have united.
This is the patient at 6 months. This one hasn't obviously been removed. So I talked about this on my lecture distinction last year on syndesmosis fixation. So the pros and cons of tight ropes and screws. This one, just to add in, is one that I've added in just because of this. When you do reduce it, and you again, this was on the lecture last year, and you have this obvious, the fibula looks quite posterior, so this is a true lateral, and the fibula is a good 4 or 5 mil away from what is the corner of the profonde. This, I would be worried about a posterior subluxation, and actually I did open the anterior aspect of syndesmosis for this, and it was posterior subluxed, and therefore I brought it forward, and this one was axially stable, which is quite rare for these type of cases, and he has had 2 tight ropes.
So as Lyndon was saying there, is that you do your standard lateral approach to the fibula, but you just go over the top. Now, obviously, AITFL probably has gum, but you don't want to be cutting into that too much. But you can just see that as you tighten your tight ropes up, that it seats within the incisura, so that you know that it's correctly reduced. If you found that it wasn't, and you couldn't play around with another tight rope, is that you can always cut them out and put another one in. And that's a slightly expensive way of doing that. So is there any way that you'd assess this, Lyndon, intraopsy, whether you think the deltoid is ruptured or?
Yeah, so this is something, again, it's a work in progress, definitely. But I started getting quite concerned that I was seeing these patients coming back with flattening feet. I don't know what you felt. You've got a longer experience than me, Andy, but so I just felt they were coming back to clinic and they were flattening. So I was ending up having to give them insoles. Functionally, they were doing okay, but they were getting flatter. So intraop, I started doing this test where, so this is one which you can see has had a syndesmotic stability, as an axially stable ankle. And then when you bring the foot, so the hind foot instability across, you can see the calcaneus has now moved a good centimetre, and syndesmosis, sorry, the deltoid, superficial deltoid, which is attached to your sustentaculum tali, has opened up significantly. And these are the ones I've started to get really worried about deltoid injuries, and therefore repairing the superficial deltoid. And obviously the paper that came out last year, published this year now, showed that TMTJ instability, spring ligament instability was all a consequence of this superficial deltoid injury.
Yeah, so I mean, there's some really good anatomical studies by, there's one, I think originally it was done by Basistas et al. In 2018, and it was repeated by Jerry O'Kane. And there are 3 slips that come off from superiorly in forming the spring ligaments. I think it's your tibio-navicular, your tibial spring, and your tibio-calcaneal. So I just would always be concerned that there is some injury to those.
And when you go in, there's usually a big cleavage there. It's all the way off, and you can if you take the hind foot, you can move it. You can really move it like into a flat foot position. And by putting these anchors in, you put one anchor in your medial malleolus, bring one through your spring ligament, one through your calcaneomedial malleolar ligament, and then if you just lift it, you can feel the hind foot swing back into a normal position, and you just tie it up. It's a very simple repair. Okay, so then do you have any questions on that one? Yes, sir.
We've got one question coming, which is from Matt Philpott. Do we need to use a clamp when fixing the syndesmosis, or is it okay just to hold the foot dorsiflexed?
So holding the foot dorsiflex will actually open your syndesmosis rather than close your syndesmosis, because your talus is wedge shaped. It's a consequence of our evolution is that to become bipedal, we had to have an ankle essentially sat and didn't dorsiflex too much. Unlike monkeys who climb trees who have very square tail leg, we had to have one that was wedge shaped. So as it's coming up into that wedge, it naturally causes your rotation of your fibula. So if your fibula's unstable, as you bring your foot up into extreme dorsiflexion, you will actually widen your syndesmosis. In regards to a clamp, I do find personally that whatever fixation you use, as you're putting the drill through, what you're worried about is that not keeping that position.
So
I personally,
for me, I'll just try and see if it's reduced. If there's any question about it, is just to clamp it, but just don't overly clamp it. And also just beware when you're putting it through the on the medial side that you're not too close to where the saphenous nerve is. So basically, look to try and see if it's reduced. If there's any queries or it's a really severe syndesmosis injury, then do so. But just always have one on the side. And I wouldn't want to start a case unless I had an appropriate size clamp for the amount of soft tissue the patient had.
Okay, fantastic. All right, let's move on to the next cases.
So this is a very interesting case. It's one of the few that I've seen in the hundreds of CTs we have of the posterior malleolar fractures. So this one has a obvious tibialis posterior entrapment within the fragment of this fracture. Would this change your approach of how would you approach this, Andy?
So I think with this, it means that you're going to have to fish this out. Now, these obviously aren't the bone images, but it's either a very large type A or there's an undisplaced type B, where the fracture between the two parts of the posterior malleolar fracture hasn't gone fully through. But with this, really, you've got to do the medial posteromedial approach first of all. So you can go in through the retinaculum, leaving a small cuff so you can get a nice repair afterwards. But you can fish this out and then just make sure that there aren't any particular tears in tib post. If there are, I'd just debride them and retuberize if necessary. But if that isn't fished out, you are not going to get this closed up. So you'll be able to fix that at that point. And it's then a question, just as Lyndon showed on that other case that we did together before, is that if you felt like you needed to have some fixation over the lateral side, actually you can feel that you can put your finger all the way across the back of the tibia, check that you can feel that it's reduced, and that it's a really easy shot to just go normally between the sural nerve and the peroneal tendons, fire a wire across and put a 4mm cannulated screw across.
I think that's the essential bit as well for this, Andy, is the fact that if you don't see the tendon, if you try to fish it out from this side and just try to flip it out, you will miss if there's a tear. So if you do have a tear, you're not going to be able to see that tear and make the obvious repairs that are required to do so. So I 100% agree with you. Okay, so this is an unknown entity, which is comminution, and this is the bit that really is an ongoing question at the moment.
So what's going through your head when you look at this?
So when I look at this, I think that we've lost something. So we've got comminution here. So yes, this one's not even that that displaced, and obviously we don't know the full story until we have the axials. But you can see here we have small little fragments of comminution as this is impacted. This also truly shows that this is not an avulsion fracture. This is an impaction injury. This is why this is a rotational pilon.
So how do you think that is going to affect the results? Does it change how you approach things to how the cases we've shown before?
Yeah, so we went back through this. So there's two papers came out this year from other units showing that having a die punch fragment actually worsens your outcome. And then one of our medical students went back through our JBJS paper. They looked at who had die punches and whether or not that changed their scores that were given. And you can see here that there's a significant difference between both on the Vasco and the OMAS, is that with a die punch, we dropped it enormously. So we certainly are still on the learning curve on this one. But for these, the problems is obviously you can't see the joint. You can't see the incisura because you have your PITFL and then your peroneal artery over the top. And then, as we know, the radiology has limited use. This one specifically, we removed the fragments. These fragments were not reducible, and obviously the incarcerated fragments stopped the reduction. So these were removed. But I do find with this compression screw, you really have to be careful, because if you over compress this after you remove the fragments, what happens? You get an incongruent joint.
So would you have a fully threaded screw then, or do you still prefer to use the partially threaded?
So no, good question. The reason why we used partially threaded on this one was because we didn't have a fully threaded screw. But I'll show with the next case now is that if you can reduce it, actually having this plate with the screws distally as raft screws, so bringing this plate much further down and using them as raft screws is a lot better. It's a lot easier then. So this one is, as you can see, is a much larger fragment. So this one is reducible. As we brought the plate a lot further down, we can use them as raft screws. And this one has this fragment has not been removed as previous.
So would you use wires around the plate to hold the reduction until you get the plate on?
Yeah, that's what I usually do. I usually get the wires right subarticular to keep that fragment in the right position, and then bring the plate down. Same with any most die punches around the ankle, so anterior, posterior. You generally open the book, bring the fragment down, close the book, and then use wires to hold that fragment as you close the book before you put the plate on.
I think I mean, you've got the screws in a perfect direction there, but it also points towards another something which I think is really important for all of these fractures, is that you need to really try and get the screws parallel to the joint. It's very easy to have your wire, say on a standard 2A or 2B, going from distal to proximal. So as you do whatever scrub, even if you don't over compress it, is that you'll find it will elevate your fragment. So I think trying to make sure that you keep your hands, you move your hand towards the head so that you're going parallel with the joint, means that you're not going to lose the good position that you've achieved beforehand, holding it with a ball spike pusher or periosteal elevator or whatever.
If you are naturally going uphill, so if you put a plate on the top of it, it does stop it progressing proximally. But we found that quite a few times right at the start of this, when you did it uphill, you got that compression and then it suddenly just moved up and you lost that reduction.
So one thing that I found is that when you have some of the bigger fragments, for whatever reason, it's actually easier to open the book so that you can get the fragments out or to push them down. Are there any tips that you've got for if it's a smaller fracture in lengthways?
So you can either go from the top end. If it's a wider fracture and you are able to get to it by the medial posterior medial, you can get the fracture fragments from the medial side, or you can go transfibular and get the fragments through the fibula itself. We'll talk about this one now as a example of that one. This one's was different to the others in that this wasn't really a type 3 fracture, but it's broken in 2 bits. So obviously it's plastically deformed your posterior profonde and then fractured behind it as well. So really it's a type 3 fracture, but with a large die punch. And this is a nightmare because it's how do you approach it? Because you can't really approach it through the medial side. So this is what spurred me on to start doing transfibular approaches, really. It's an example of this one. So you can see I've put an osteotome through the fibula fracture, and then as I've impacted this, then I've been able to bring it down back to the joint level, and then I've fixed it a wire to keep that in position before putting the plate on.
Yeah, so I think one of the things that you're saying there is that compared to the one before, which is not a reasonable sized chunk, but it's not extending right into the midline as that one is, and it's very difficult to get that from the back, isn't it? Is that I think you would tilt it, or you'd be having to press it so hard, is that I'd worry that you'd crush the back of it and nothing at the front. So I think trying to get your position is very, very difficult for a true die punch fragment like this.
Yes, is there any questions for these ones?
Yeah, so on the topic of fixation, you've shown we briefly touched on that. Some people I've seen or use partially threaded screws, a combination of plates and cannulated screws. So what's your preference here? And does it really matter if we were to use a fully threaded screw or a cannulated? I know that you said overcompression might be a problem, but can you?
So it's good question. So when people come back to clinic, if we got a kind of general clinic, I can look at the X-ray and know that I haven't operated on them. I usually can know who's operating them because we all have our signature moves, if that makes sense. Yeah. My signature move is generally a small plate in an anti-glide position initially. I'd put a partially threaded screw to compress and to prevent it migrating if my position is not right, as Andy said earlier. And then I would complete it with some further screws around it to lock it, stop rotation. So that's my signature move. And that's because my personal feelings, I like a compression across a joint and I like an anti-glide to start with, and then I add another one in to prevent rotation. What's your feelings, Andy?
So Lyndon has slightly more patience than me. I think previously, especially when we first started doing this, there were no plates that fit on the back, and it can be a bit of a pain between them and then bending them a lot and things. When I very first started trying to fix these, there were no plates that fitted them on the back, so we just got used to using screws. I think as things improve with regards to anatomical plates, is that if a plate can help with reduction and maintaining that reduction, it is better to use. I don't think pull-out strengthening is that important, because once it's fixed down, I think these unite pretty quickly. But I've tended to use screws in the past, although my practice is changing at the moment.
And you use partially threaded screws as well, then?
Yeah, I would tend to use partially threaded screws. As I said, it depends what availability you have of 4mm fully threaded screws, is that we don't tend to have them. So it really is a case of, if it's one of the ones where you've taken out those sort of small fragments, is really you just want the head touching the cortex. What you tend to find with these is that if you try and do it like sort of you're fixing a subtalar fusion, where you're really cranking that screw in, especially if the fracture is like 3 weeks old, is that head will just sink into the bone, or it will split the fragment. Is actually you're trying to hold this in position with either a ball spike pusher, or a Langenbach, or a periosteal elevator, and then the screw is just holding it there. You need to have your reduction first of all, and then fire as many wires as you need to in that without splitting it, and then put your screw in, and that's just to hold it once it's in position. You're not really trying to crank it.
Now, just a quick question, one from Sarang Kasturi. Any situation where you would use a syndesmotic screw instead of a tightrope, and do you think screw would do better in situations where you have used 2 tight ropes or required 2 tight ropes?
So my personal viewpoint of that, as we said before, is if you need to control it axially, I think you need to have at least 1 screw in there. I think sometimes in elderly patients, especially if they're osteoporotic, or even just locally feels like it's significant osteopenia, is having some transtibial fixation, especially if there's a medial injury, I think will prevent it going into valgus afterwards. I think, as Lyndon showed with the second syndesmosis case, is having the 2 tight ropes. There isn't any evidence for this, but it just makes me feel quite happy if you've got them going in divergent directions, that hopefully you'll get it seated within the incisura. What do you think, Lyndon?
Yeah, I agree. If you're thinking that you're looking at a super construct, so you're worried about either you got comminution or you're worried about a fragility, then I wouldn't use a tightrope. But I would use a tightrope if I'm not worried about those, and I got a young patient, for example, you want to try and maintain some movement. Getting divergence, I think it's a theoretical benefit, but it's you then controlling both anterior and posterior, both translation and rotation.
Okay, thank you. Let's move on. I think we've got probably time for 2 more cases, if we can.
Yeah. So because this was a above and beyond posterior malleolar talk, I've added this one in, which was a rim fracture, which is a bit of an oddity. But not only that, as you can see for the CT, it is a very large fragment, but it's due to sort of how do you approach this? How do you get to this bit? I know how I approached it. Andy, how would you approach it?
So I think with this is that you're going to need to be able to flip this down. So I'd probably use a posteromedial approach on this. You might be able to go medial, posteromedial. I'd need to look through the whole of the scans really. But I think the key is that you need to be able to actually probably medial, posteromedial, and posterolateral approach. I think looking at the there, and you need to be able to open the book and flip that round. Now, one of the problems here is this: the medial fragment at the back, is if you're going to fix that, is you can see the discoloration of the tibialis posterior groove. So you can't have anything in that because it will impinge. It's really tight in adherence as you go there. So the medial medial approach will allow you to flip the tibialis posterior over the front of that core, the corner, and then you're going to need to fix it. So if I was going to fix it, it would need to be with a headless compression screw. I must admit, I don't particularly like the plates that sit down in that because I'd just be worried about them abrading against tibialis posterior, and you're going to be in all sorts of trouble there with trying to perform a reconstruction if there was a problem. And also, if you needed to go in and debride it, 'cause it was tendinopathic in that area, I think you're going to find that the anatomy will have moved around quite a bit, and your chance of neurovascular injury would be increased.
Yeah, we're singing definitely from the same songbook on this one. So exactly your tibialis posterior, which is going to be lying here, is over this interval where your fracture is, and essentially you can go both ways with the medial posterior medial, and that's the way I did it. And I agree with you. I did a headless compression screw to ensure that it wasn't anywhere near your tibialis posterior tendon. Because I agree with you, anything that goes down that groove, I'm very, very worried that it will, they will irritate that tendon.
Okay, so if we do this as our last case, and then we can go to comments, really, this next one. So here we've got a rather sporting fracture. I think that's quite the biggest one I've seen. So how are you going to approach this? Because when we look at this, you think, do you go front, do you go back, do you go somewhere in the middle? How are you going to approach this, and in what order?
So for me, this is this is the highest one I've ever seen in my practice. The most extensive approach we have is the medial posterior medial. So when you get about 1 Muller square above your tibial profond, you can see the entire back of the tibia. So from there up, essentially, you can see the entire back of the tibia through the medial posterior approach. And because it is your medial extensile approach for, so if I show that, it's your medial extensile approach for your compartment release. So it's very safe as an approach. You can see your saphenous nerve and vein just in front of it, but you can see it all the way up. So for me, this one, it's very easy to approach from that to get your apex in and get some compression across. And then your anterolateral fragment, so you can see on this, is a straightforward anterolateral approach. I would tend to do the top bit first, just to get my length, because that makes it much easier to get your anterolateral fragments down. We just have to be aware, don't put anything from the back to the front that might stop your reduction of the front. Because it's very annoying if you've got the patient in that position, for the back to front screws, and then you can't reduce that, and then you have to go back to the initial fixation.
Yeah, I completely agree. Is that what you want to do, as we originally taught with, like, say, true pelon fractures, is you want to make sure you've got a constant fragment, and it's so much easier to do that by keying in the top of that bit at the back, and then you know what position you need to put that anterior part in. So what position would you have the patient in for this?
This one was the recovery position prone to start with, to do the back, and then I've turned the patient, much easier to turn the patient from that position to a supine position than it is from prone to supine, but I've done it through the back and turned the patient.
So if you just put the patient prone, you can do that, but you're going to rapidly fall out with your anaesthetic department. As sort of reiterated at the start, is that you're in a lateral, the upper body is almost in a lateral position, although the bottom of the body is in a prone position. You can very easily take them lateral and just flip them onto the side. So doing both of them, and you can get to them easily, and the anaesthetist won't hate you forever for doing it.
Yep. And that's so my signature move, as we found out earlier, of an anti-glide plate and a compression screw, and then completion of the plate has been done both front and back. He done very well. This was his 6-week x-rays. He was from over the water, and you can see that it's not quite healed at this point, but he was doing very well at this point, out of a boot.
Okay, well, I think we'll probably call it a day with the cases there, if that's okay, Yasser?
Yeah, that's fantastic. Thank you very much. That was an amazing lecture. Not only did it cover all of the possible scenarios that we could possibly have, and not only helpful for FRCS, but also for I think pragmatic daily approaches to these fractures. So thank you both very much. Questions about positioning, as we talked about now, and approach. So if you do have a 2A type of fracture, a large posterolateral, but you have quite a long or a comminuted fibular fracture, do you then do a posterolateral approach and make separate windows for your fibular fracture, or do you have something else?
Yeah, so I can start with this one. So I tend to look at the fibula, look at comminution, and know my how difficult it is to fix the fibula through that approach. So I'd much rather do a direct lateral and just do a posteromedial approach. When you do a posteromedial, you will see your posterolateral fragments. It's pretty straightforward. So I will tend to do a separate lateral and then a posteromedial.
I will tend to do that slightly differently. It depends on the size of the patient, but if they're of a reasonable size, I think that you can actually do a posterolateral incision, but the posterolateral incision I'll do will be between the Achilles and the sural. Because you only need to make quite a small incision for these small type 2A fractures, and you can fix that, and then you can do your direct lateral. So depending on what the morphology of the patient is quite often I'll get you can actually almost do this in a lateral position, get the foot up on a big black block so that the leg remains parallel. You can do your posterolateral incision, you can go in, fix that one fragment, and then it's very easy to do your fibula. Lyndon's better at doing things upside down than I
am. Thanks. And then when we mentioned about the overcompression of the posterior malleolus as well, quite a lot of times there is the comminuted area which is missing, so you can't really actually assess. How do you assess overcompression then? Do you have any tips or tricks to say will prevent overcompression?
So I think one of the ways is to look at the apex. So that apex needs to be keyed in. So if you've got, say, a ball spike pusher or peristyle elevator, whatever you're using to compress it, don't put it right down at the most inferior part of the fragment. Try and put it sort of in the center where normally there hasn't been a big bit which has gone out, and put your wire across. And I say it really is just getting the head of it to touch the cortex, no more than that. Do you do anything different, Lyndon? Or?
Yeah, no, it's similar. So your initial reduction has to be at the apex, because otherwise what you do is you tilt into the defect. So you have to be at the apex to keep that defect open, really. And then when you are putting your screw in, do it under X-ray. So when you get in down to the bottom, before you start to tighten it, do it under X-ray. Because I have personally done it before. You over tighten it, you can see the fragment do that, and then you get essentially narrower tibial profond as you do the talus. So it's more get them last few turns on an X-ray.
Okay, and then last question here. On case 4, what happens in case 4 if to the plate if you remove the screw and leave only the tight rope through it? Will the plate rotate?
And if you remove the screw, usually you're removing it at about 12 weeks. My lecture last year said that you really shouldn't be removing these screws before that. And if you are removing the screw at that stage, you'll tend to have enough fibrous over that plate that it's not going to rotate.
Okay.
In that case, you could have quite easily used 2 screws as well.
All right. I think that's. Thank you both very much. As I said, a fantastic series of cases here, which are amazingly helpful to everyone. Thank you both, and we'll see you next week on the 27th for the next BOFAS Lectures of Distinction. series. Okay, so stay tuned. Good night.
My name is Andy Jones. I'm the CEO of Ramsey here in the UK. Ramsey Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsey Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsey hospitals to refer their patients for high quality healthcare. So Ramsey has got a long-standing set of values called the Ramsey Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsey Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsey, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.